Hello, everyone, and welcome to the Quorum Podcast. This is where academic medicine meets remote, austere, and resource-limited areas. Welcome back to the program. This is Ava Kelly. This week, we are with Dr. Alastair Fraser, who chairs the advisory board for the Faculty of Remote, Rural, and Humanitarian Healthcare for the Royal College of Surgeons of Edinburgh, and was the first chairman of the new faculty. Alastair, welcome to the program.
Thanks, Eric. Thank you. Thanks for the invite.
So tell us a bit about yourself and what's keeping you busy.
What's keeping me busy? Yeah, I'm a UK physician. Qualified in Aberdeen some time ago, long time ago. Spent a winter in the Antarctic. Went into surgical training. Went offshore with Shell in the North Sea doing search and rescue. To Oman, looking after desert clinics. Onto Sarawak. Looking after offshore and onshore facilities, and dealt with the haze that first the forest fires, some public health. Back to the UK, looking after UK operations. From there to Houston as a corporate medical director, so first experience in large corporate. And from there to Nigeria, looking after, I think, soon about 40 community hospitals and various other things that we were doing. From there, ended up back with Shell in The Hague, the corporate centre, and ended up as vice president looking after basically the delivery of health across Shell globally, which included everything from toxicology to risk assessment to medical to hospitals to links with health insurance. So it'd be a fairly broad and varied job. And left that a couple of years ago, and I'm now director of a company called Noyos, which does gaming. We put positive psychology interventions into sandbox games, and we're just putting together our package for longevity. So we're moving into the longevity space as well. So that keeps me busy. I think it gives some idea of where my interest in remote, rural, and humanitarian medicine comes from, because it's kind of what I've been doing all my career.
I did not know you spent a winter in the Antarctic.
I did, yes, yeah.
Tell us about that.
That was fascinating. One of the best decisions I ever made was to go to the Antarctic. I was at a place called Sydney Island with the British Antarctic Survey. That's just in the Antarctic convergence zone, so you have the sea defrosts over the Antarctic summer and freezes over the winter. We had 16 people overwintering. We had no way in and only really very limited communication. So I think my claim to fame, I was doing what I believe is the first ever root canal treatment in the Antarctic.
Wow.
Never having done a root canal treatment ever before in my life.
You had the kit to do it?
Yes, had a dental drill, mirrors, and not necessarily the skill set.
Wow. That's fascinating. And 16 people in a closed environment. How was that with psychological issues of close compartments and only 16 people? How was that?
It actually worked remarkably well. British Antarctic Survey did an interesting screening program. They took everyone down to Cambridge and took them rock climbing, basically gave them too much to drink at big parties, and anyone who misbehaved at the parties or was a pain, or anyone who whistled at breakfast the following morning didn't get to go.
Sounds like a scientific approach on how to get people to work together.
It's actually not a bad one when you think about it. Not much in the way clear standards, but it was very pragmatic, and they mainly picked a bunch of people who did get on well together. It's a good place. A lot of wildlife. I learned to scuba dive there, which was interesting.
I can't imagine how many layers you had under your dry suit.
It was a wetsuit.
Go away. Wow, that must have been freezing.
Well, you tended to lose close to 2 degrees centigrade on a good winter dive.
Wow, that's amazing.
Yeah, I think safety standards have changed since then compared to what we...
I can imagine. I have done a lot of cold weather diving, and there's a profound difference between a dry suit and a wetsuit, and dry suit is mandatory.
I wouldn't even consider it in a wetsuit. Not a chance.
Yeah, not a chance. It's interesting you mentioned the pints as far as coalescing a team, and In Special Forces, we do the same thing. When a new guy comes on the team, we'll go out for a bit of a night out, and just to see how people get on, and it's a good way to have a cohesive training, a cohesive environment when you go out and let people kind of let down their guard, and you get to see what they're really like.
No, I actually agree. I totally agree. In fact, I think the uh, almost pushing the social circumstances far beyond what you would normally see as acceptable is it's quite a good way to test what you're getting.
Indeed. Of course, alcohol is not allowed in the South, is it?
Yes. Oh, yeah.
Oh, no, really? Yeah. Well, okay, that made things easier for you, I suppose.
What's really terrifying is you have to order up 18 months to 2 years worth of alcohol before you go.
I'm not sure how long it would last if I was down there for a winter.
Yeah. How honest can you be if you're ordering that much alcohol or that little alcohol?
I'll have to tell you, I would have to go to the Royal College of Surgeons of Edinburgh and get some of that 1505 whiskey that I like and get that down there somehow.
Well, that was not a problem. You could order anything. I think gin was something like £2 a bottle.
Ooh.
So we used to use it to clean the windows because it's very good. We had so much of it.
Wow. That's fantastic. Any other medical issues you had down in Antarctica, other than the tooth thing?
We also had some, it had a first seal bite, which is not very bad. It wasn't a particularly bad one, but we have a nasty habit of going wrong. It's a sort of mixed anaerobic infection you get from them, and they're very hard to deal with. It took 6-8 weeks of recurrent cleaning and dressing to get it fixed for a very, very small nick on a finger.
Wow. So
that was always interesting. What else did we have? Well, we actually went on the way down. We had a malignancy aboard the ship, which again you diagnosed based on nothing. It's purely clinical, and any decisions you make are massive. If you send someone beyond the Falkland Islands, who actually now has to be medevaced, it's a major logistic operation and it's not without risk. So this person, he ended up being medevaced from South Georgia.
Wow.
And got back to London in 72 hours, thanks to the Royal Navy.
That's pretty impressive.
So from clinical diagnosis to specialist care in London was just over 4 days.
Wow. That's amazing.
So that was quite, again, it gives you some feel for the kind of challenges, because it's not just medicine. You have to do it. You have to trust your gut. You have to every decision you make down there disrupts ships, disrupts logistics. Every small decision has big impacts. I'm not sure we desperately teach people how to do that. Desperately don't do that very well.
Did you have ultrasound or X-ray? What diagnostics did you have?
We had X-ray, wet film developing. So you had to do tanks and develop it in the dark room.
Wow.
We had ECG.
Wow.
That was it, really. But you could do a blood film and you could get a hemoglobin, but that was your lot. There really was nothing else. And the ability, we did have a trial at one point of slow scan television. I would imagine that most of the audience for this podcast wouldn't even really know what that is, but it's like watching a TV picture build one line at a time.
Wow.
If there was no video, you couldn't do standard video.
Right.
Didn't exist.
Wow. Well, at least you could do blood smear. You had staining in a microscope, did you?
Yes, you could do that, yes.
So you had differentials.
You could pull that together depending on how skilled you were at that, using a book to remind yourself of how to do it.
Our quorum field guide is down there. One of our students took it and left it in the library in the Antarctic station.
Excellent.
So in that field guide is differentials and blood smears and how to do that.
Yeah, I think one of the challenges with all these things is you have a book, you do what you're doing, and then you have to somehow reach some degree of certainty that what you've done is correct, and that your interpretation of a blood smear is correct. And not having it as part of your routine skill set that you do every day, you add a fair degree of error to it.
Thankfully, telemedicine is making that a lot easier.
Totally, yeah. So it's a very, very different world now.
So you spent time in Antarctica, and you said you lived in Nigeria for a while.
I was in Nigeria for 4 years, yeah, looking after sort of West Africa. So I looked after Nigeria, Cameroon, and Gabon. Mainly to set up HIV programs. That was the primary focuses at the time when HIV was really surging in those parts of the world.
Wow.
So that was interesting. And then we did outreach, community outreach. So we did a bunch of community hospitals we supported, and we put together a new model for basically how to create a hospital that functioned in Nigeria. So we had one called Obio Cottage Hospital, which still runs. It still makes money. It's still profitable. And its performance figures for obstetrics is roughly kind of middle to Eastern Europe. I don't mean to be offensive, but it's to anyone in those areas. But it went from being basically about 98th percentile bad, really into about 2/3 of the way up. So really quite decent mortality and child mortality figures. So
Impressive.
very satisfying to see that. Yeah.
And what organization were you with when you were living there?
Shell.
Oh, part of Shell. Ah, brilliant.
Yeah, we don't. I think Shell doesn't like to tell people that they do good things. I think it spoils the image.
No doubt. So you've had quite a few different postings with Shell.
Yes. Yeah. It sounded quite odd to say almost 30 years with one company, but I went from the corporate medicine in the USA and negotiating with healthcare plans and unions and all sorts through to, basically Sarawak, looking at offshore, to running things in strange parts of the world. So like when we go to Greenland, doing offshore seismic in Greenland, how do you set that up and run it? And so I stayed with one company that which was changed totally every 3 to 5 years. It just did something completely new, which was great.
Did you get to pick the fun things to do?
No. No. It was fun. Like, well, you get to apply, but then you get also told you might want to apply for this.
Well, you worked your way up to vice president, so you were making policy.
Oh yeah. No, at the time, the Shell Health, as it was known, was kind of a standalone organization. We had over 500 people in the health function, and we were in 22 countries. And we also did the toxicology of products, product safety, and all the risk assessment, health risk assessment piece. That was in part of Shell Health. Statistics, so there was a lot of research statistics stuff that was done as well, on top of the occupational health and the managing, provision of, say, offshore services in the North Sea. So yeah, quite broad.
And all of the offshore medics working on the rigs, they were reporting to you. Is that right?
Yeah, yes, and most of them were actually were contract, so they work for people like International SOS or other contractors. United Healthcare was part of the contracting group at the time as well. So most of the medics came from contractors. They would report through the various teams. So the medics in the North Sea would report through Aberdeen. Aberdeen reported to you, you reported to me.
Oh, so quite a few echelons separating that.
Oh, there was quite. It's a very big, complex organization. Yeah, so a lot of structure to it, and actually, one of the things that makes it work is having appropriate structure.
Were you able to make some changes that made the whole situation better?
I would say so. Yeah, I did a lot of simplification work. So we had a lot of processes that were running that were just enormously complex. We used to do a lot of medical exams that had basically very little value. But I still think doctors and medics are not very good at predicting the future. I think overall, the future is one of the things you should not predict. Probably the only thing you shouldn't try and predict is the future.
Fair one.
So we sort of simplified that. We also did a lot of work on. It was initially handed to me as stress, and I say I'm not doing stress. That's a ridiculous concept. So we did resilience and building on positive psychology. We expected to do the programs in the cognitive behavioral therapy based approaches for teams delivered by the team. So it was on paper with little exercises. You need a decent paper and stuff. And that got rolled out globally. It worked. We've seen improvements in resilience that were clinically, or if you like, humanly significant and also statistically significant. And it got rolled out across maritime, so I think probably a couple 100,000 mariners have been exposed to at least some of the modules. And it went as far as small to medium enterprises in Uruguay, which came as a surprise, but they approached us. It rolled out in Dutch schools via the University of Utrecht. And it was rolled out to the internally displaced people due to Boko Haram in Nigeria.
Huh.
Because they have no facilities and there's no psychological support for people who are exposed to some of the most just appalling violence, sexual violence and all sorts. And the stories that came back from that, unfortunately, yeah, numbers to back up, but the stories that came back were astonishing. How much difference it made giving people basically a space to have guided discussions on how much of a difference it makes to life. So yes, we made quite a lot of changes.
It's interesting, the psychotherapy or the mental makeup of some of these offshore medics or remote medics, or no matter where you are. Everyone refuses to acknowledge or think about the psychological issues, pressures of some of the jobs that you've been overseeing for the past few years. And I'm delighted to hear that you're using, well, CBT has some fantastic research behind it.
Yes, yeah. I agree. I mean, I think for one of the reasons that I got involved early on in kind of moving towards creating what becomes the faculty was I think we actually asked an awful lot of medics. So medics are, I'll be provocative. Medics spend a lot of time in the North Sea sitting in the bus drinking coffee. The nature of the job is such you're not busy all day, every day.
Right.
But when the shit hits the fan, you get busy very quickly and you're on your own. And you're being asked to deal with pretty much anything. And it's not just the big trauma, it's some of the more smaller things that could be serious. And we just ask an awful lot of folk to do this, and it puts a lot of pressure on people. I've seen one medic in the North Sea, not long after I arrived off there, we had someone crush between two containers by a crane. I needed attention pneumothorax. I had come and was gradually turning blue and not doing very well at all. And I had just come from trauma surgery. So I started a chest drain in because that's what you do. Didn't even consider that there was anything else to do. Diagnose it. No x-ray, diagnose, chest drain. He's a lot better. Sorted. You could send a doctor to take him ashore. And I turned around to look at the medic, who by this time looked like he was having a myocardial infarction in the corner.
Yeah, the 4-week course the HSE has for the offshore medics doesn't really prepare you for those major issues. But
and it also doesn't prepare you for someone you've never met walking in and sticking a chest in into your patient.
Yeah, that's very true. But I mean, even though you have to be a paramedic or nurse to get the course, it doesn't really prepare you, does it?
No, I think and it's a shame because when the Pipelines Act was returned and the medics parts of it were defined in legislation, it was a huge step forward. Unfortunately, it's then defined in legislation, so it doesn't move. It takes too long for the measures. There should be a need for training with some standards defined, but it goes too far, and it then leaves people stuck with out-of-date training and some really, really varied quality of training providers.
Oh, definitely.
And I agree with you as well. I think 4 weeks is way too short. There should be ongoing video training. There's so many opportunities now that should just be routine for these folks. And this is the structure that could be there just now, where if you have something that's difficult, you're not sure what it is, which you will come across, because it happens to all of us. You call a friend, and there's a friend who can look over your shoulder.
Right.
That's just not there.
So you and I had talked about enhancing the capabilities of the offshore medics, and we discussed ultrasound, which has been around for ages. But I guess if it's if the HSE offshore medics is stuck in legislature, there's zero chance for improvement. Is that you can't add an ultrasound device to the job, can you?
Well, you have to persuade the company that's running the platform and paying for the service that they want to pay for that, and the extra training and the extra time off. And Some will and some won't.
Yeah.
And some look on it as actually taking on extra liability, because there's a mindset among some of the platform operators and some in maritime as well, is that if you get the person on the helicopter and they're heading off the route, that's it, problem solved.
Mm.
It's not solved to the individual necessarily, but you've got to have access into the mindset and into the systems and into the wallet of the companies doing it, because the legislation says you don't need it.
That's a challenge, isn't it?
I think that's a challenge that the faculty should be chasing as well.
Yeah, let's talk about that. So let's talk about the Royal College of Surgeons of Edinburgh and the faculty that you helped create. So what is the Faculty of Rural Remote Humanitarian Healthcare?
Yeah, good question. Well, first thing, start with the Royal College of Surgeons. It's been around over 500 years. It's under a royal warrant. It's a charity. It's by definition independent, and it's recognised globally. So it doesn't give you a license to practice. And initially it was just surgeons. It doesn't give you a license to practice, but it gives you recognition of your competence. So RCSEd, Fellow of the Royal College of Surgeons of Edinburgh, is a globally recognised set of letters that you can put after your name to show that you passed the exams and you're reasonably competent in your field. So that's what the college did. Underneath the piece for the college, there are faculties, and they are specialised areas. So there's certain one that looks after, for example, pre-hospital care. So trains people who deliver, for example, car crash in the west coast of Scotland, and you have to get them to a hospital and then on to a trauma centre. That training is not necessarily part of normal medical student training or nurse training. So they provide training in that space. They set standards, they check that people are competent, and it's a very useful thing. The faculty started off basically looking at doing something similar for medics. I mean, that's where it basically came from, is we needed to do something for medics in the North Sea. So that was the first little bit coming from the Institute of Remote Healthcare, is we need to do something for medics. And as soon as you start scratching the surface on that, you realise it's a much bigger topic than medics in the North Sea. It's a global issue around quality of training for medics, quality of competence, to go beyond the problem we just discussed, which is some of the medical stuff is embedded in legislation. And if it's embedded in legislation, it moves slowly, but medicine actually moves fast. So how do you move that forward? So the faculty started with remote, and then it became very clear as we were sort of putting it together that rural medicine has the same issues. So you have a mixture of doctors and nurses and medics and ambulancemen and physiotherapists and pharmacists and all sorts who deliver the package of healthcare in rural communities. But healthcare has been designed by basically large tertiary hospitals and academia. So how do you translate the kind of healthcare you inherit from a large hospital into a small community somewhere far away and remote? So all of a sudden, what became remote and rural. And then the humanitarian folks who along said, look, this is kind of the same for us too. If you put doctors, medics, nurses, take whatever category you would like to do or label you like to put on it into humanitarian circumstances, we're not really training them very well. So the humanitarian group joined in because there's so much overlap between the three topics. It does make it a bit of a mouthful as a faculty, though. You know, rural humanitarian healthcare, isn't it? It's not quite the same as the Royal College of Surgeons, but it does at least flabby.
Yeah.
And the faculty, basically, the idea is it pulls together a community of people who are interested. It goes beyond what's routinely in these faculties, which is it's not just for doctors. It's not just for medics. It's for anyone who's interested. So if you are a health manager looking after a program, you can join. You don't even have to be clinical to join, which I think is classic. Because when you think of how do you deliver healthcare in remote, rural, humanitarian circumstances, you need everything. You can't just have a doctor or a medic with a bag. That doesn't work. I mean, it works, but you're missing out on a lot of the opportunity for your patients. So that's where the faculty came from. Initially, small, this looking at must-see medics and recognizing we were not we weren't getting the most out of them we could, and not giving them the best opportunities that we could as well. And then it just built. As soon as you start building, next thing you know, it gets a lot bigger. And we're now at the stage where we've had our first bunch of fellows and members assessed, and they have now been awarded fellowship with a capital S or membership with a capital M of the faculty. And this will build. There's another application running out there, and this will build over time. And we create a community. And I think that's really tremendous. I mean, that's the first steps.
Indeed. It's been very interesting to see this come to fruition from the very beginning. I was in Edinburgh with you in 2017, I think, is when we started with the concepts of IRHC, and then started adding on more and more interested parties, such as Humanitarian Healthcare, and we kept meeting every 6 months or so, trying to put in the capability framework and educational standards. And we have another meeting today, of course, online on trying to move this forward. But let's start with the fellowship and the membership. So we have fellows and we have members of the faculty of rural remote humanitarian healthcare, and we have the postnominals of what's FFRRHHED, which is I'm honored to have that, and I've already had someone look at my business card and said, "What did you hit your keyboard with your forehead? What's with all the postnominals there?" But tell us about it. So, what does a fellowship give a paramedic, a nurse, a doc that's going to benefit themselves?
And again, this is early days, so that's the first thing. So it's not particularly recognized globally yet. It's only just picking up and going. Once it's much more recognized, or we start to build things into legislation and start to alter the way that healthcare is delivered in these settings, having a fellowship is independent recognition of your contribution to the field and your capacity to deliver in the field. So it says this person has done a good job, not just for themselves, but actually for the whole field of remote, rural, or humanitarian. In many ways, fellowship is you get that as you have climbed up the career ladder, as you take on bigger things. It's more about looking at systems, but having had experience in the field, so you don't get it for just doing nothing, just the leadership pieces. Membership, I would look on as this is membership with a capital M, because you can put that after your name as well. Well, it starts with an F, you start with an M. And membership is basically recognition of achievement of someone who's in training, or who is building their way up through the ranks. If you put it into a hospital sort of approach, if you think in terms of a UK hospital, and I know many people not recognise this, but it's just an example. Membership would be given to someone who's done the work, done the training, and they're a sort of a registrar. And fellowship is for a senior consultant, if that makes sense. And it just recognises your contribution and achievement in the field. It also would be the sort of thing that perhaps if I was writing a contract in Shell now, and this was more available, I would perhaps specify for our medics that I'd like them all to have membership. Because it shows that you've been assessed by an independent organisation and you've got experience, training, and are progressing. So that's I think given time, it becomes a contractual opportunity as well, which drives quality standards and the opportunity for medics.
So for the medic or doc, paramedic, nurse that earns their fellowship with the faculty, what does that do for them? What is there a community they're engaging in? Do they come to Edinburgh once in a while to have meetings with us, or what is the day-to-day difference for them?
I think at this, again, early days, there are certain benefits of being with all of you. Get access to educational materials, access to courses. There's communications and various pieces that happen. I would hope that maybe next year we will have the first of the conferences where the faculty will actually drive a conference, at which point people will get together. We will almost certainly host a large dinner in Edinburgh, and people come, and you start to meet your peers and start to create that community that you talked about. What, again, a challenge for anyone working in the remote and rural space is making friends, because everyone is scattered. So how do you meet people? How do you have people you can share ideas with or talk to? Because they're scattered across the planet, and by definition, they're remote. So I think that is, as the faculty goes in numbers, and we start to have these conferences and other events, I think it's going to really pull together a large community, which will be helpful even in day-to-day. If I think back to my time where I was working offshore in the North Sea, I remember having a case which was obviously madness with low velocity coastline outside horizontal snow, and you're in the middle of the North Sea and you've got a case and you're really not quite sure what's going on, and you're not quite sure how serious it is, and you're limited in your diagnostic capacities because you just are. So I called up our topside support at the time to see if there was someone I could talk to just that ideas back and forward. And I got someone whose first response is, well, why don't you send them ashore so I can have a look at them? And you kind of go, you really don't know what you're talking about. Now, if you've been in a helicopter and 48 pound launching off a platform in the North Sea, you don't do that lightly. And I think we need to find ways to create the community so that when you talk to someone, your topside support, your medical support, or your colleagues, that they are competent and they understand the challenges of remote, rural humanitarian. And humanitarian, I mean, you've just been to Ukraine. You have to be kind of careful.
Definitely.
You don't ship people around the Ukraine unless you have to.
True. Yeah. Or sub-Saharan Africa, or I mean, humanitarian healthcare encompasses so much. Yes, what we did in Ukraine was definitely part of that, but so is all the work that we do in sub-Saharan Africa.
Absolutely.
Yeah.
And unless you have an appreciation of it, and you've even had some training to, basically to have the cognitive framework to say, these are the sort of things you have to think about before you medevac someone. Or how do you treat them better on site? What can you do with limited resources that would be acceptable, but perhaps not, Harvard Medical School? And there's a lot of thought process has to go into this, and I think people should be trained in how to do this.
So there's initial training that we talked about, but with the faculty, are we looking at options in the future for facing this issue of how do you have continuing CPD? How do you have update? How do you get someone involved in CBT that's going to benefit them when they work in rural, remote, or humanitarian healthcare?
I think that's one of the basically important roles of the faculty. It's one of the core roles. We're in the process just now of, we're just about ready to publish a competence framework that covers remote, rural, and humanitarian. It's not just clinical, it also covers things like logistics, it's management, leadership. How do you make a team? How do you get a team to work in these areas? How do you cope with stress yourself? So it covers, it's a very broad look at what's required for competence in these areas. So that I think is piece of leads up to now you've got a framework. Who's providing training that the faculty could independently look at and say, yes, this person is providing really good quality training in this piece for, I think we talked it before with yourself, I think this with the Ultrasound training that you were doing. Yep. So the faculty can have a look at it, and you get independent experts look at the training and go, actually that meets what's required. And we can then have a list of, if you are a medic and you want to go somewhere and learn how to use ultrasound, speak to ABRIC.
Yep, that has been helpful for us so we submitted our ABIS course, Austere Pre-Hospital Ultrasound course, to the faculty, and we have Royal College of Surgeons of Edinburgh's approval of the curriculum. So it's great because we know that we have peer review on our course. And is that an option for other people to submit their courses to our faculty for review and approval?
Absolutely. And very soon, I mean, I'm saying yes, absolutely. You're aware of what's in this competence framework. Most people won't be because it's not published yet. Once that's published, I would very much like the faculty to be pushing to get more people, more or more companies to come forward. You have a look at the course, you peer review it. It's done by an independent group who actually the faculty doesn't provide training. So there's no conflict of interest in this. This is just about raising standards. And I think we should be doing that all across the board, right across the board and across the planet.
Agreed. There's definitely a need for third-party verification of what's being taught out there.
Totally. Yes, absolutely.
Yeah.
So there is huge variation. I'm in Kazakhstan. I talked to one of our contract medics there, young guy, good guy. He was a neurosurgeon. In Kazakhstan, you become a neurosurgeon 2 years after being a medical student.
Oh, wow.
I don't know if that's changed now, but at the time, that's what they did. He wanted to learn, and there were no courses available that would help him to do that in Kazakhstan. And as a neurosurgeon, he was, well, I think 2 years after medical school is not really a lot of training to become a neurosurgeon.
Indeed.
So you need to give more training, you need to have access to it. And so much of this training, a lot of it now you can do online. So if someone's sitting in a porta cabin in Kazakhstan, as long as you've got a bit of an internet link, can download courses, run through it, independently verified, and at the end of it, you can get some form of educational credits, CME, quarterly, whatever it would be. And that's, again, another area that needs to be worked. Is that the college doesn't just peer review your course, as they did with your ultrasound course, but actually then says, yeah, we would support you in getting some form of educational credits for it that people can use.
That's something that I brought up at our last meeting, and I've been pushing for to have the option of like having peer review course is brilliant. So our APIS has gone past a number of people in the college who are experts at what at ultrasound or what we were submitting. But why not have EU credits, college credits, university credits, and or physician CPD credits for these courses? So at the moment we have one. We have one course from the faculty, and at the moment it doesn't give any CAPC credits or physician credits, but we're working on that. So tell us. So we have one course. Tell us about that course and what's available free of charge.
Oh, right now, the one course that comes out is the Humanitarian Healthcare course, available online. Yes, outrageously positive reviews. Not outrageous because this is a very good course. So the people who have taken it come back very positive about it. You get a certificate to say you have, what did you say, attended or completed the course. There's presently no accreditation CME educational credit for it, and I think that's just a crying shame. And as to what comes next on that, well, I hope you'll write up your little piece for this, and we submit it to the exec committee of the faculty, and we move forward to look for various forms of educational credit for that course. So the course stays free, because that gives anyone who wants access to it, which I think is how it should be. But if you want to have your educational credit, something could be CE or points to, yeah, you pay for that. So you can have the education, but if you want the credits for it, you pay for the credits. And we'll say, well, I think we will get there. One of the things I didn't really mention about the faculty is it's voluntary. The faculties are what's a charity, and it's run by volunteers. So there are a couple of basically 2 administrative staff who look after the faculty part-time. We've got access to the various functions inside the Royal College, which are, these are people in careers and paid for it. But the whole clinical medical healthcare aspects of it is delivered by volunteers. No one's getting paid for it. So it doesn't make the faculties particularly fast.
No, true. I mean, it's been 6 years for us to get to this point. Yeah.
Yeah, and I can only blame COVID for so much.
Yeah. So your goal is to have more online courses similar to what we currently have.
I don't think that's yet. So I think I would love to see us with more online courses, particularly the ones that pull together the disparate pieces of working remote rural humanitarian areas, but also then link to providers like yourself or to other people who are providing good quality courses. So you would probably come to the faculty, look at the faculty course in remote to just pull together the various skills you have, but you'll be getting your other courses from your local providers, folks in the US, folks in sub-Saharan Africa, whoever's providing it. And those would all be stamped by the faculty as an independent organisation, no financial interest in it at all, and they'd be stamped by it, and you can basically fill up your book of, these are the courses I've done, this is what I've done to pull them together, these are the educational credits I've got for it. So I would like to see lots more of this happening.
I completely agree. And one of my passions is creating academic backing for austere medicine, rural, remote, humanitarian healthcare. So my part, I mean, you graciously invited me on the faculty advisory board, and I've been blowing that horn for 6 years now of we need academic backed. And the college is doing that. The Royal College of Surgeons is doing that. But I'm still pushing advisory board, yourself, even further to get university credit, get doctor credit, CAPC credit, paramedic credit. So these people who are going to be doing the tons of online courses that we're going to be putting out eventually, so that they can get a piece of paper that does something for them besides just getting the course. So I mean, at the moment, we're giving a completion certificate for the online free course. That's fantastic. But what about getting university credit or CPD credit as well?
Yeah. You no pushback from me at all, Luke. None at all. We will make this happen. It takes a bit of time. One of the challenges with the faculty as well is that I think we need to go out. Having come from big corporate, I think we need to go out and find some more money. And if you've got more money, you can employ people or companies to deliver, create courses, to deliver things. You can do a lot more, a lot quicker than if you just rely on volunteers. You need the volunteers to ensure that it stays independent and reduce conflicts of interest and other things, but you need money and support. Part of the money comes from people joining, membership, being part of it, but I think we also need to be going out and tapping companies and foundations a bit more.
Indeed.
To bring in the money to allow us to move forward much faster.
Alastair, my final question for you is this. What advice do you have for the new paramedic, new nurse, new doctor interested in working in austere environments?
Well, you love these pieces. You've got to join the faculty. It's really important.
Agreed.
Terrible piece of simple publicity there. But joking apart, I think that it's before you get into it and deeply into it, but you need to find some people. Talk to them, find out what it's about, find out from them what they've done, what they found useful, because there's no standard of training, there's no standard of experience, there's no curriculum just now to do these things, to go to sub-Saharan Africa, to work on an oil camp in the middle of the desert. There is no training for that at present that's really competent out there. Some organisations do decent training for their people. Certainly International SOS, and I see we're doing some quite reasonable training. You need to be out there talking to people and understanding what they're getting into, and get some training before you go. I think the other thing that's becoming more and more and more important is become IT literate. I mean, you can't just rely on Microsoft saying, if you've got a huge computer above you, just reboot the computer 15 times, it will work. Yeah, you've got that's easy, isn't it? You're going to be out there in the field, but it's standalone. You've got to understand how the equipment works. So not just the medicine, not just the clinical, but the equipment. And I think the final piece is challenge yourself. Are you really up for it? And this is an area I think is fascinating. If you look at the medics, the doctors the nurses who succeed in these remote and rural austere areas, they're a fairly special breed. It's not just technical skill, it's the ability to survive in a small community, it's the ability to thrive in a small community and to drive change and to act as a health leader in those communities. Think about those areas. And that's an area I'd love to see us, the faculty, getting into, is how do you define what's the psychological criteria for success for people working in remote rural humanitarian? Who are the people who do well at it, and who are the people who really would need to go and train? Maybe go and get some CDT, understand yourself, understand what drives you, I think we're a wee bit away from that, but I think it's required. I don't know how you think of that. With if you look at the most successful medics and people working in these areas, they are a bit different.
We're a bit strange. Yes, we're a bit different, but
Yes, I was being polite, but yeah, strange.
Yeah, because we are comfortable in very uncomfortable environments.
Yes, you've got to be really happy with uncertainty.
And how do you train that other than putting them in an uncomfortable environment and shaking them up a bit and then seeing what falls down? And how do you train for that?
Well, the thing is, I think we can train chunks of that. There's various discovered courses in the UK now who look at putting people under pressure to deliver quality care, urgent care, and basics does it. The bunch who do the helicopter ambulance service, they do pieces where they put people under pressure.
Yeah.
Deliberately. So I think you can do that. I think you can probably say there's some evidence that you can, if people understand the thinking and understand what's going on and understand some of the cognitive processes that are happening, you have more choice in those areas than you might think you have. And I think there's literally a training that you can do, almost classroom training.
We see a bit of stress when we run our courses in Malta due to the live actors and lots of red stuff coming out of them. And we have seen people break down with that amount of stress, even though coming from a special forces background is not huge amounts of stress, but it's that is needed, isn't it? So if you do want to be in an offshore or remote or humanitarian environment, you need to learn to work under duress.
You do. And also under surprise, because it's not working in a casualty unit, AV unit, where people are being brought in every day, every hour with something serious wrong. This will be someone you had coffee with an hour ago, and next thing you know, they're in front of you with, as you said, less stuff coming out. You got to be able to switch from drinking coffee to full-blown emergency room in no time at all. Not everyone's happy doing that.
No. And there's a bit of a disconnect, I think, speaking as a paramedic, because you don't know the yoke that you're working on. So it's just some guy that got injured. But when you work in rural, remote humanitarian healthcare, you're often friends with the people that you're working on. And that's a bit of a challenge.
Correct. Yeah, you know them. You know them. You'll know most of them, at least to say hello to. And some of them, they will literally be your friends. So it's just different. So yes, please apply pressure. Try not to break anyone. I think that's also very important. So it's the correct amount of pressure. But I think we can do more in that space so that we end up with people who actually enjoy it and can deliver for the people who are ill or injured and don't harm themselves.
There's hope that they self-select out of the training before they get into a situation where they could be a problem.
Correct. Yeah, absolutely. And that's part of my comments earlier around go talk to people, try to get your head around what this means, and actually then be honest with yourself. Is it for you?
Alastair, it's been great talking with you. It's been something I've been wanting to do for ages, getting you on to the program. I am impressed with what you're doing with the faculty and with the Royal College of Surgeons of Edinburgh, and I look forward to seeing you in December.
Excellent. And thanks for the invite, and really happy to be here. If there's anything else to do, please share. Thank you.
This has been a presentation from the College of Remote and Offshore Medicine. If you would like to earn CPD credits for this podcast, you can join the Council of Members. Being a member of the college gives you free CPD credit, free access to our virtual field guide, and discounts on our e-learning courses. You can join the team on our college website at quorum.edu.mt.